Welcome, everybody, to the Primary Care Seminar Series for this academic year. I'm Dr. Sara Fazio at Harvard Medical School. I'm the Director of Primary Care Education here, and really so happy to be leading us off. Today, we're going to be exploring the very important intersection of primary care and the carceral system. And I'm going to do a brief intro of our panelists, but then have them talk a little bit about their own pathway. So Dr. Laura Hawks is a primary care provider in the Division of General Internal Medicine at the Medical College of Wisconsin. She's an assistant professor at MCW and a part-time clinician and part-time public health researcher. Dr. Matt Tobey is the founder and director of the Rural Medicine Program at MGH, which includes the MGH Fellowship Program in Rural Health Leadership, as well as partnerships between the MGH and both the Rosebud Sioux Tribe and the Indian Health Service. He works in primary care and inpatient care in Rosebud, and he used to be the faculty director at the Nashua Street Jail until 2019. He's an assistant professor at Harvard and trained in both internal medicine and addiction medicine. And last but not least, Bryan Winters joins us. He is a community health worker and an advocate at Aurora Healthcare. He's the founder and CEO of Mending Men in the community and is joining us from Milwaukee, Wisconsin. So we are streaming and recording, as you saw this session today. We'll have about 45 minutes for moderated conversation, and then we're going to open it up for Q&A from the audience. So I am so excited to introduce all of you in your current role, but would love to hear about the pathway that brought you to this work. Laura, would you like to start for us?
Sure. Yeah. Thanks for having me here. I'm really excited to be talking to everyone today. I guess I'll just jump right into the question, which doesn't really have a quick or simple answer. I think as many of you all are now medical students, it started first my sort of interest in specifically understanding how to improve, or how to understand how the criminal legal system impacts health and then undermines health, and then how to improve health. For folks who've been involved with the criminal legal system, started in medical school for me. I went to med school not too far from Boston in the Bronx, at the Albert Einstein College of Medicine. And over the 4 years that I was engaging with patients there, just realized how pervasive criminal legal system involvement was in the patients I was working with. Uh, how it was undermined, ways that it was really hard for folks who'd been recently incarcerated to get risk factor control across a broad range of medical conditions. And then also sort of along at the same time, learning more and more about, from a sociologic perspective, about the system of mass incarceration, and understanding just how at the at the country level, not specific to anything healthcare related, it was just such an omnipresent system in our society. And learning more about the ways that it was disproportionately experienced by patients of color, and people who are of lower socioeconomic status. And so that's where I guess my interest started from, and built from there.
So thanks, Laura. Matt?
Great. Well, thank you so much for having me with you all tonight. So I'm an internal medicine doc and an addiction medicine doc. And today I work primarily in partnership with a community out in South Dakota, which is a little different from what we're talking about in this session. Back when I was in residency training, I had the opportunity to participate in a training elective that involved going to a few county jails and seeing how healthcare was delivered. It was actually coordinated by another doc, Sarah Wakeman, who's done a lot of work in this space, and as was very much a mentor to me in those years. And there was an opportunity through what was called the Crimson Care Collaborative, which was a Harvard Medical School student clinic network, to have a clinic in one of the county jails in Suffolk County. So that's Boston's county. And there was another doc who'd started it off, but was moving to the UK. And I had the opportunity to take that position as the faculty director of that student clinic that was embedded right in the carceral system, which was quite an experience. There were countless Harvard Medical School students, PA students, NP students, residents, including Laura, who passed through that clinic for those years. My wife was the dental faculty who provided care there, and a friend of ours provided psychiatry care all at the same time. And, you know, it was a little bit of a crucible for the social and medical issues that are, you know, intrinsic and really challenging in the carceral system and in the healthcare system. So, you know, it's wonderful to be here tonight and to reflect on some of those things. I will say, you know, to this day, I help out the Harvard Medical School students who are working at Nashua Street Jail. There is a group that still goes into the 2 county jails in Boston to provide health education, and they have a really lovely program. So, you know, I still help mentor them. And I also do what Sarah Wakeman did for me, which is that I help coordinate uh, all the residency programs in Boston. If there's a resident doc who wants to go to one of the county jails, I'll help facilitate that. So we have agreements set up with 6 different area residencies for those training rotations. And, you know, I do this all as a volunteer now, and I think that gives a sense that it feels like there's a lot left to do, you know, and I hope there remain folks who are interested in this space in the Harvard system. And, you know, I'd love to help make connections and keep people having the opportunities to learn more about this space, which has, you know, countless issues. So again, thanks so much for having me. Pleasure to be here. And it's great to be here with Laura, who I know is a leader in this space. So Laura, thank you so much for the work you've been doing these years. It's really inspiring. And there's lots of amazing work in medicine that, you know, I think is helping clarify those questions that you raised, Laura. So thanks for walking the walk all these years. And then it's great to meet Bryan, who I don't know yet. So Bryan, I think you're probably next, but thank you so much, Dr. Fazio.
Thanks, Matt. Bryan, thanks so much for joining us. Tell us a little bit about how you got involved in the important work that you do.
Well, good afternoon, everyone. Thank you for having me here. I appreciate the opportunity to, share any information or insight that can be useful to anyone. Well, first, what got me here is the part I've had the lived experience of some of the issues and some using the medical inside of prison. But then I'm also a community health worker now for a hospital here in Milwaukee, Wisconsin, where I work with individuals we call returning citizens that are coming out of prison or out of any of the county jails here, and I connect them with primary care. And I get to see not only from my own experience, but I get to see what others have been going through as far as the medical attention that they get there versus what they're getting out here. And when Laura asked me if I would, want to join the panel and be a part of it, I was definitely, up for it. So I just think it's an opportunity to kind of enlighten some people about the things that they go through and help them figure out some ways that they can make those things different.
Awesome. Thanks so much for joining us. I'm really glad that you came today and that Laura invited you. Well, let me jump into some of our questions, and Laura, perhaps I can start with you, and then I'll ask the same question to the others on the panel. How, in your perception, does incarceration shape health or access to care, both inside the carceral system and after release?
Yeah, that's a great question. And like my last answer, multifold response. So I think one thing it sort of Matt mentioned, thinking about our carceral systems as a place where there's like a crucible or concentration of folks who have had poor access to healthcare throughout their life, poor access to the social determinants of health, multi-factor adversity, and so there's much more chronic illness, infectious disease, substance use disorders, mental illness going into the prison system. So it's a population with high needs to begin with. But it's actually a lot more than that. I think sometimes you might, if you're looking at it on a superficial level, you might just kind of stop there and say, well, these people are poor, and they've experienced a lot of adversity in their life, and that's why they're so sick. But it's become pretty apparent through the research of many people that incarceration really serves as an exposure that independently makes people less healthy and confers a lot of health harming effects. So there's maybe a more really easy to connect the dots example would be opioid overdose. So folks who have opioid use disorder may go into the state prison system or their local jail, probably first, having been in a state of active opioid use. And when they get to the jail, their access to that medication or that substance is no longer available to them, so they stop using. And we have good medications to treat opioid withdrawal. They're opioid agonist therapy, buprenorphine and methadone. But historically, and this is not as true in Boston anymore, thank goodness, but still widespread around the country. In Wisconsin, it's largely the case still. People don't have access to those medications when they enter the state prisons or the jail system and then the prison system. So they go through withdrawal. Which is a deeply uncomfortable experience. And then they, have the remainder of their incarceration without much use. Certainly some substance use happens, but on average, people use much, much less than when they're in the community. And then their discharge or release without access again to these medications we know are extremely good, better than almost any other medication we can prescribe for any other condition at preventing the negative outcome, which is opioid overdose. And so people now have a very low tolerance because they haven't used in a long period of time. And they're at high risk of relapse because they haven't been given the resources they need, the medications or the social support they need to not relapse. And so they're at extremely high risk of opioid overdose. And we know that this pans out in the data, right? People have like a 240 times increased risk of death after they're released from a carceral setting if they have had opioid use disorder going into their incarceration and are not given medications to treat it on the way out. So I use that as an example that's really easy to explain. This is the pathophysiology that's like any other condition you can learn about in school, in your courses. But it's actually true for a lot of other conditions too. So you think about diabetes, where the data isn't as strong here because it hasn't really been studied as much. But certainly there's some evidence to support what I'm about to say, which is that people who have diabetes going into prison are diagnosed with diabetes while they're in prison. We know that the most important thing about maintaining control of your diabetes is self-care behavior, right? So what happens in your clinic appointment is important, but the most important thing is that you learn the skills to take care of yourself. You learn how to eat healthy. You learn how to get the exercise you need. You learn how to identify your own triggers for something that might cause a hyperglycemic or a hypoglycemic episode. You learn how to check your own sugar. You learn how to dose your own insulin if that's the appropriate thing. And the prison system, you don't learn, there's no autonomy in prison. So if you are diagnosed with diabetes while you're incarcerated, you are not set up to learn the skills that you need to learn to take control of that, especially once you're outside of the prison setting. Maybe when somebody else is making the decisions for you while you're incarcerated, you'll actually have a decent control, but you'll have experienced substantial degrees of loss of autonomy and loss of the skills necessary to maintain your good health as a result after you've been released. So you can kind of describe those circumstances in which the setting of incarceration is actually undermining somebody's ability to manage their chronic disease. And then I won't spend too much time here, but the ways that a criminal record, and also the experience of reentry undermines even further your access to the social determinants of health is really unlike anything else you experience besides, maybe immigration limitations. But there's really not any other experience like it in our society, where it's undermining your access to employment, undermining your access to your social circles, undermining access to health insurance, incomes, really everything, not to mention the discrimination that people experience and the perceived discrimination that limits their desire to seek help. So it's really the answer, again, as I mentioned, is multifold. That it can be analyzed across the spectrum of or the time course of how one experiences incarceration, but it's really formative in all of those moments.
Thank you, Laura. That was incredibly helpful description. Matt, anything that you would like to add from your experience?
Yeah, I'll add a little bit about the experience of healthcare, in carceral facilities as well. So, I mean, in addition to losing all that self-efficacy that Laura's talking about, which I think is so important in healthcare, right? Health-seeking behaviors, if you have chest pain, going to the hospital, right? Like choosing to go to the hospital, it's very different if you've spent years of your life in a setting where you're under such intense control. I think that is a real, risk that people face after they've, for returning citizens. And so that's very important. Part and parcel of that, though, is that when you're in a carceral facility, you're reliant on that control system to take care of you. And I think that is also very scary for people. Like if you're worried about your health and you can't get the system, the correctional officers, the jail-based healthcare team, the nurses, to sort of pay attention to what you're worried about, that is a recipe for disaster. And there are disasters that happen in healthcare in these settings. Unfortunately, more than I think anyone would like to consider. And, this is often, we learn about them through lawsuits at times, with carceral facilities. There are some efforts out there to, improve the quality of care that's delivered in carceral facilities. There's a accreditation body that will accredit, they'll go into jails and prisons and take a look at how the clinic's operating, and they'll say, hey, this is like up to snuff. And, those efforts I think are very important, but it's optional, and many facilities don't have that sort of, they're not meeting standards in any sort of measurable way. And so, it creates this environment that's very frightening, I think, especially for people with health conditions, or at least it can be. And, there are certainly horror stories that you hear about, including in, facilities that I've been in some, proximity to through the years. And so, in order to get seen, just to paint the picture a little bit, you often have to fill out what's called a sick slip, which is a little sheet of paper where you have to write down what's going on with your health, why you would want to see a doctor or a PA or an NP, or have a nurse check you out. And then that gets screened by a nurse usually, who then, will either put you on the schedule or try to get more information. And, for folks for whom English is not a first language, for folks who might be having some sort of reason why communication is hard, for folks that are withdrawing, when they're first admitted to a facility and they've had an active substance use disorder, those are really high risk situations where, in the years that I was involved at the jail, I saw some really tough things that happened in that way. There was, somebody who English was not a first language, who had terrible heart failure and was basically between the ICU and the jail multiple times. I mean, it was, there are many anecdotes, and I probably am best not to share too many of them, but, this is a really fraught healthcare environment. The facility's first priority is security and not necessarily the health care that it's providing. And, many carceral systems really do want to provide excellent healthcare. It's not, sort of malicious, but it's hard to have a well-trained staff that's, 24/7 attentive to what they're hearing from the population of a facility. So, those situations are real, and they happen everywhere in the US every moment. There's somebody who's having chest pain in a jail somewhere or in a prison, and, you know, you hope that these systems are operating the way that they can and should, but it truly is, you know, these situations are really challenging for people who've been through them, and you know, I think it's hard to recognize that as people who haven't spent a lot of time, and even I who don't spend much time anymore, you know, in these settings.
Yeah, no, thanks, Matt. For those of us who haven't spent time providing care in such a setting, I think it's you both provide such stark evidence to demonstrate why outcomes are likely as poor as they often are. Bryan, what has been your experience in terms of your own experience and helping others? What kind of concerns get overlooked, or care do people not get that they should be getting?
Well, quite often, and I kind of want to comment on something like Laura was saying. A lot of it do start prior to even going to incarceration, because you know a lot of people go when they're younger. They go into prisons and things like that. So they go from their parents or guardian or whatever setting everything up. Then they go, that's how they know to go to their appointments. That's who they know who to talk to if something isn't right. And then they have that gap in time where they're not going to see anybody quite often, and then they go to prison. And in a prison, you or jail, or whatever, you don't always get the the person that you may be writing this slip to saying that you need to go to the doctor, or they make a decision whether it's important enough or it's severe enough for you to be seen. And sometimes if they look at you and you don't look like anything is wrong, then it's kind of like, okay, are you just using this as an excuse to try to get out of your cell, or you trying to get off the unit? Is something really going on? And I personally, I had that issue because I had chronic back issues, and things like that. And it was always, well, you don't look like anything is wrong. Or, you know, I know one of the institutions I was at, there was individuals who they kind of screen at first. You know, they'll look at all your requests and see if it's important enough. So they say the nurse has too many people to see. So if it doesn't seem like it's important, then you can just write a note to them, and then we'll see what they say, things like that. So there are barriers that are in place that prevent, you know, from you getting the medical attention that you want. And then you have people a lot of times that aren't even physicians that are telling you, well, you don't look like anything is wrong. And some of those, a lot of things that could be going on, you might not necessarily look a certain way. They're going on internally. You know, you can't look at somebody all the time and say, oh yeah, you have a migraine, severe migraine, or you can't look at somebody and see back pain. But then there's also the cases where individuals don't submit those requests because there's a $7.50 fee that goes with those as well too. So now you have a choice. Do I spend my last $7.50 to see someone who may just give me some Tylenol and say, you know, this would be better, or do I use this for food so I have something to eat throughout the night or things like that? So that's another barrier that's in place there too, you know, because there's this cost attached to it. And if you're seeing and you don't get it taken care of, it's still $7.50 that's gone from the individual. And everybody doesn't have those available funds. One thing I can say though is that if it's for the same thing, they don't charge you the additional 750 every time you've been seen if it's a continuous thing. So that does work, but then there's times when they do, and then you have to be able to know who to write to get reimbursed that money, which is a whole another process.
Thank you, Bryan.
And
That's
just one little additional point of context, because I think for a lot of us who are outside, $7.50 copay sounds like a dream. That would be amazing if we had that kind of copay, but you have to put it in the context of people who are incarcerated usually get paid somewhere between like 40 cents and $1 per hour. So you know, the amount of time one has to work to earn that $7.50 is sometimes a week, 2 weeks worth of earnings. So it's not something that is trivial at all. And oftentimes families don't have the families outside don't have the funds to supply the commissary for the person's personal funds so they can afford those kinds of things. So it's really a huge amount of money in the context.
Wow, thanks for the explanation. I wanted to ask a follow-up question for any one of you. You spoke quite a bit about autonomy and the loss of autonomy. I wonder, what about confidentiality? I'm guessing that that is significantly compromised, but can anyone speak to that?
Yeah, well, there's something that is talked about in carceral medical services where the, physician, say, is employed by the jail or the prison. And the jail and the prison has a different set of priorities than the Hippocratic Oath. They are running a carceral facility. And so there's this double loyalty that physicians have to navigate to their patients as well as their employer. Like imagine if your hospital had like a social agenda, that was like out of step with providing the best healthcare. Like that would be a very challenging set of considerations to navigate on a day-to-day basis. I remember this is all old news. I would not assume anything I say is true these days. And fortunately, there's been a lot of change for the better. But when we were working in the jail, that if the local physician thought that someone should be referred out for specialty care, maybe they had a mole they were worried about, or there was a joint problem, or maybe rheumatoid arthritis or something, they would actually have to place the referral to their contracting company's uh, uh, person who then reviews them all and rations the care out, basically, who has to like approve each referral, because part of their contracting company's pitch to the jails was that they were inexpensive. So in order to manage costs and reduce costs, they would disallow referrals that they didn't think had been adequately managed, to the degree that a local team in the jail can manage them. So, even these docs who, were absolutely quite good, like there were actually some phenomenal docs at the facilities we were at, they wouldn't be able to get their patients the care they thought they should get. And, they'd often be exasperated at this person. And I actually talked to one of the people who was doing it once, because she was like a residency friend of a med school friend of mine. It was just a strange thing. And she's like, wait, don't you know this person? And, she was like right out of a preventative care residency, like had never really worked in the carceral space, and was just like, I think scared almost to be doing like what she was doing, denying healthcare to people for some corporation. But also, just trying to work a job. And, these structures that we set up are really profound. Like, I'm sure people are shocked to hear you have to pay money for, to be seen in a facility where you actually have a constitutional right to healthcare. Um, so many of these things are just, I think, baffling to those folks who haven't experienced the system before. But this is everyday business. And, and that's part of why I'm so passionate about trying to get people exposed to these issues. If people who are going through Harvard Medical School never have a chance to hear about any of this, then I feel like we've done society a disservice, where we're the nation's doctors, and the nation's carceral system just don't have the opportunity to work out their differences, almost, if you know what I mean.
Yeah, I appreciate your saying that, Matt. As I reflect on what the three of you have said, it just strikes me that the moral injury for a physician trying to do the job must be huge. And I can't imagine that there are that many people who are able to do it for sustained periods of time. Laura, I wonder if I could ask the next question to you. Speaking at the other end, that when patients are and individuals are transitioning and leaving incarceration, what are the biggest systemic barriers that they face? You've highlighted a number of them, all of you already. And how does stigma in particular affect their inability or ability to seek care?
Yeah, great question. And I know Bryan will definitely be able to speak to some of this, and some of what I know because Bryan's taught me. So I'll try to point it out for those points. But so Bryan and I actually we got to go to Washington, D.C. on sort of behalf of the state of Wisconsin with some state policymakers. We don't have the most progressive reentry health policies here in the state. And they were, part of a team to try and improve some of those things. And so the DOC reentry guy was there, and he is really well-intentioned person there because he wants to make a difference, there to challenge his own thoughts. And he's like, well, one of the first things he said, well, like, we know that people are leaving they're leaving prison with insurance. We have the data. Like, there used to be abysmal. People had horrible Medicaid enrollment rates, and now we have the data that's much better. Like 75% of the people versus 10% 10 years ago are leaving with Medicaid enrollment. And Bryan's like, well, I'm showing up to the healthcare appointments with my patients, and they have Medicaid enrollment, but it's not activated. Like it's not their card is not something they can actually use to get healthcare services when they're immediately walking out of prison. And again, we don't know all the reasons why that is, but we know that people have in Wisconsin, they don't terminate Medicaid, so it's just suspended. But if you've been incarcerated for more than a year, you have to prove your income, which is a little silly because you've been incarcerated. So, most likely, there's been no income in the last year. It's been minimal. It's obviously assets and stuff are another story, but there's these logistical barriers that are not built into the system. And when they are built in, they're oftentimes not sufficient. So again, our reentry team in the DOC thought that they were doing what needed to be done. And the data was telling them that they were being successful, but it was the real life stories of the patients who were going to their appointments with their Medicaid cards and it wasn't activated. That's actually, the lived experience of the patients. So anyways, Bryan, that was Bryan who taught me that one. Another thing, to sort of think about is the medications people are discharged with. So oftentimes they're given 30 days supply. I think policy or like best practice now is to provide a 90-day supply. But it's really hard to find a primary care doctor, and it's an even harder job to find a primary care doctor who takes Medicaid. So if that's your insurance coverage, getting an established care visit within 90 days can be really challenging. And that's even if you have like all the resources you need to navigate the healthcare system. And so much less finding someone who can meet your needs. If you have mental health needs or addiction, you need someone to prescribe you buprenorphine. Being able to know exactly who is available, who's taking new patients, who's able to help you specifically with the medications that you need to have filled. I would say those are the two most common, like, specific healthcare navigation barriers that I see.
Yeah, thanks so much, Laura. Bryan, it sounds like you probably have a lot of experience with this type of question.
Yeah, I do actually. And I was just thinking, another one of the issues is uh, there's no, in most cases, there's like no smooth handoff or anything to go from this prison um, healthcare to out into society, where it's completely different. They're not connecting you with the primary care physician prior to your release. So, like I was mentioning at first about people go in, and a lot of them went from their parents handling the healthcare to the prison handling the healthcare. Now they're released and they have to figure it out on their own. And that's what, like, part of what I do in the role I do now is I get the opportunity to go into the prison prior to them being released, and I get to start talking to them about healthcare. And so the hospital that I work for, the clinic that I work for inside the hospital, we start building that relationship with them prior to their release. So even if we can, we have them an appointment to establish care set up within the first 2 to 4 weeks after they're released. So they have to want to be a part of that. And this way it makes it a little bit easier. And then me as a community health worker for them, I'm able to help them with that transition. So the questions that they may have upon their release, they have someone that they can reach out to. And understanding the rapport that's built between me and them, one, because they can relate to me because I've been in the same situation, similar situation as them, leaving incarceration. So things like that help. Uh, but what's missing is a lot of them they're just released and they don't know what to do. They don't know where to go. And I know this particular institution, they were given 30-day supplies of medication, but then it changed to a week. So now they have 7 days of medication to try to, it didn't have to try to figure out how to connect with the doctor, how to find a primary care doctor. And like Laura was saying, which ones accept Medicaid? Is it convenient for me to get there? Then you have these other social determinants of health, transportation. Um, you have to worry about your other priorities, employment. You don't want to get out and just be living off of other people. You need somewhere to stay. A lot of people are released with nowhere to live. Think all these different social determinants of health, they come into play and they become barriers when they don't have someone that they can connect with. Even when they do have someone to connect with, these barriers still stand to be an issue. So I can think of a few other reasons why, but then you have mental health plays a part about it. If a person, they're trying to take care of their mental health and they're having whatever medication was given to them in incarceration. So now when they're released, they're not thinking right away a lot of times, like, I need to be connected with somebody right away. And then they run out of medication. So now they're in the emergency room for whatever. They have an episode or they just searching for someone or may just need some medical attention and they're using those emergency rooms to get that attention. Versus if they would just had someone to kind of connect with prior to that release and get some of those things set up that they never had to do on their own before, it'd be a lot smoother.
Wow. It's mind-boggling. We think care is difficult, in the usual kind of system. This is absolutely horrible. Thank you for sharing those experiences. Matt, along the lines of what Bryan was just detailing, in your experience, what sort of partnerships between health systems and community organizations can be most effective in supporting reentry?
Yeah, absolutely. Well, I may turn some of this to Laura and Bryan, but the gold standard of doing this work is what's called a transitions clinic, where you have a dedicated clinic outside, in the community that takes care of people specifically who are transitioning, who are returning citizens. And so that's a beautiful model. There are several of them. I think Laura probably knows that system quite well, so I'll let you comment more in a moment, Laura. I will say the other thing that's easily overlooked um, in the healthcare system is the value of community health centers. I think there are so many federally qualified community health centers in this country. The movement dates back a long time into, I think, was it the 60s when Jack Geiger was sort of helping set up some of these original community health centers. I mean, it's an amazing story and one that I think we overlook all the time. I mean, having these community-based practices that are designed to be able to care for anyone who comes in the door is a remarkable feature of our health system, and one that I think, sometimes is met with a shrug, but I think this is a great example of where, this is a value that's really important. If you're in a community and your local community health center, about it, that's a place you can go and they will help you get enrolled. They will help see you. And, they will, I think in many cases in the US, treat you well. And I think that's a special thing. Anyway, Laura, pick it up from there. I'm sure you got a lot more to say.
Yeah, I think I completely agree with your thoughts about the community for the FQHCs, the federally qualified health centers. They're absolutely here in Milwaukee a super important, if not the most important, infrastructure tool that we have to provide care for people who've been incarcerated. and you know, Bryan works for, not for a community health center, but for one of the 3 large health systems in our city that also does a lot of that care, just especially because of their proximity. Their big hospital is close downtown to where people are released from the one state prison that's in Milwaukee, and also the jail. So I recognizing the importance of those centers as the you know, the pivotal points from a healthcare perspective for these patients is important. And along the lines of the transitions clinic, I would just say the real heart of that model. So it's, you know, the model for folks specifically designed for folks who are returning home from prison is to connect them via healthcare, but the community health worker with the lived experience of incarceration is sort of the crux of that model, and sort of recognizing the importance of somebody who can be trusted. You know, as physicians, we don't actually we aren't necessarily assumed to be trusted, especially in a population who have often not been served by the healthcare system, even before their incarceration, and oftentimes during their incarceration as well. And so having a personal relationship with somebody who can be trusted and be trustworthy, and be the voice of a system that should be trustworthy as well, is actually a really crucial component to that model. And so I think trying to recognize and build up the capacity to support the peer community health worker model is super important to these transitional programs.
Thanks so much, Laura. Bryan, can I ask you a question? Maybe you can follow up a little bit on what Laura said, but as you're thinking about that partnership question, I wonder, what role can primary care providers play in help rebuilding that trust? Because I don't think it's something that we think about too often, and I think we really ought to. But how can the primary care physician help rebuild that trusting relationship?
Well, it started off by just, treating the person as if they're human, speak to them, ask them how their day is going, just acknowledge them as an individual, as a person, and take the time to ask if do you understand this, or do you need me to clarify anything, and just being open and welcoming. A lot of time, no matter what you've been incarcerated for, there's the stigma. People look at it like they think you're a certain way, but just want to be treated fairly like everybody else. You want to be respected. You want to be taken well care of. You want to walk into a place where you feel like you're welcome, and you want to talk to somebody they give you the feeling that they're open to answer your questions, that they care about what's going on, and not just going through the motions to kind of get you out of here, move you along, because that's what they were just coming from, and when they were incarcerated. And not necessarily because this is how the nurses there wanted to treat them or whatever. And that goes back to what Matt was saying. Like, they have this dual commitment that they got to find some type of common ground to try to make both sides, happy and things like that. So just approaching them and addressing them just like they would anybody else.
That makes a lot of sense. And having time to build those relationships, I would imagine, once you find them, can be enormously helpful.
Absolutely.
Just one bit of practical advice is not to be too curious about what their actual criminal history is, as much as you probably are curious, and that you can acknowledge that's a normal impulse, or an understandable impulse to understand. I think trying to, oftentimes over the course of a relationship with the patient, you'll learn a lot about their history, but and sometimes it's important to know what their substance use history and mental health history is, for sure. But to try and give the patient the space to be the person to share that history with you, and put it into their control.
That's a really, really good point. And thank you for making it. I suspect it's incredibly useful for people to hear what not to do in these settings as well. I guess my next question for you, Laura, is what forms of advocacy have felt most impactful to you, whether at the bedside, in the community, or in policy spaces? Like, what can be done and is being done that moves this needle in a positive direction?
I think most, for me, the most promising and most fulfilling things that I've done, in my relatively short career so far, have been to build these partnerships with communities. So Bryan and I are on a community partnership grant with another organization to actually design and implement the first CHW training in the state prison system, so that we're actually training people who are currently incarcerated to become community health workers. And Bryan's one of our lead mentors for that. And that was really, the whole program was designed out of conversations with people who aren't necessarily physicians or nurses, but are really interested in trying to promote the health and wellness of folks in reentry. And so we still have a lot of work to do with that to make it successful. But so far, it's been a really important, I think, learning experience about centering the experience and the what's important to folks who have been incarcerated and are closest to the experience. And then I would say the other thing is just to be really tuned into to what's needed locally. So we have 50 state prison systems in this country and hundreds of local jurisdictions. And so what is important here in Wisconsin is very different than what's important in Massachusetts, and probably what's important at anybody's home, in anybody's home state, assuming they're not from one of those two places. So the need of every system is very unique, and the only way to learn what the biggest needs in your system are. Like in Wisconsin, we need better access to medications for opioid use disorder. We need to pass the reentry waiver to use Medicaid funds to support transitional services. In Massachusetts, you already have both those things. So that doesn't mean there's not a ton of work to be done in Massachusetts. It's just very different than what's needed here.
Point well taken. Absolutely. Bryan, what experience, in your experience, what has allowed you to sort of motivate others to become community health workers? Like, how are you able to inspire people to do what you do?
Well, it actually is a lot easier than one may think, because this is when it comes to the healthcare, it's not something that people don't want to know, and people, they like to help people, if they can help their family out in some kind of way. They want information. Like a lot of the gentlemen who I'm in correspondence with now with the program, they talk about how, oh man, my mom has this type of illness. She has this going on, this going on. My kids this. Now I have a sense of what's going on, or how to advocate for them, or how to make those connections and things like that. So they're enthusiastic about learning these things. They were just most often never really exposed to it, or never got the proper care that they needed to know about it. And I think back to what Laura was saying about, like, if you're diagnosed with diabetes while you're in there, you're not going to get this plan or have the freedom to do certain things that you need to do in order to keep that diabetes well managed and things like that. So they just letting them know, like, hey, you got the opportunity to learn this, because they're learning something new, and they're learning something that's beneficial to them and pretty much everyone they come in contact with. So they are naturally enthused about it. And then to hear that there's an opportunity in the healthcare field for someone who does have a criminal background, that is like the thought of what they can become is life changing alone.
Yeah, no, that is fantastic. And what sounds like such a critical link between one system and finding your place in another, for sure. Last question before we go on to audience questions. I'm going to ask each of you to answer this. Whoever wants to start, what advice would you give to medical students or early career clinicians who want to work at this intersection?
Yeah, I'll start. I think that it is, one might assume, based on some of the really challenging information that we're sharing right now, that it would be terribly unpleasant to be a healthcare provider in these settings. And the exact opposite is true. Like, it is a wonderful place to be a compassionate physician. People are wonderful anywhere you provide care. And the added benefit of being in a place where people will really appreciate you for treating them, as Bryan, you said, with dignity, respect, and, giving you a fair shot is really affirming, and I think it affirms all our medical training that, we have something of value to give, and that we've been trained to treat people with respect. And in few other settings is it such a transparently positive sort of exchange that you have. And perhaps it should not be so positive, but that is the state of affairs. And so, uniformly, I think there's fulfillment to be found in doing this work. And I think especially if you're working on the larger issues, as folks like Bryan and Laura do every day, it's a pathway to a very satisfying career and life. So, I respect you two so much for what you're doing, and I'd recommend that to anyone listening.
Well, that's wonderful to hear. Laura?
Yeah, I just wanted to completely second that. I have no doubt that the learners on this call are deeply compassionate people who are going to be able to connect with people across all walks of life and in all stages of illness. And so I think that assuming you can show up with a genuine sense of compassion and wanting to understand, you'll find the interactions very satisfying and fulfilling. And I also think that, in thinking of the words of Bryan Stevenson, a different Bryan, I think also spelled with a Y, who is a national leader in health justice. I mean, sorry, in justice. He found the Equal Justice Initiative in the South. One of the things that one of his tenets is to get proximate. And even if you aren't going to go into a career in carceral medicine, or you aren't going to become a carceral researcher, you have an opportunity now to understand what it's like to be involved in the criminal legal system. And if you're going to be a doctor, no matter what kind of medicine you're going to do, you should get as proximate as you can to these patients in this moment, because it will carry you through. If you're an emergency room doctor, a trauma surgeon, a cardiologist, no matter what, you will be working with patients who are interfacing with the criminal legal system, and it will put you in a position to understand their needs and advocate for them in the moment when somebody else may not.
That's incredibly impactful advice. Thank you, Laura. Bryan, what's your advice?
And I was just gonna say, keep an open mind and always approach it as a partnership. Involve the individual in their care plan. Be patient with them. Try not to focus on the fact the individual has been incarcerated. Focus on their health and how you can work together to better their health.
That's incredibly helpful advice. I think it hits the nail on the head. I have one question right now from our students. Can the differences between the duty of the carceral system and the physicians who work within them be reconciled? Anyone want to take that?
I'm not a medical ethicist, but I believe the answer to that is no. That there is just an inherent there is an inherent tension between not to say that it shouldn't always be strived for, but like, for example, it's really hard for prison facilities to practice harm reduction because it's certain types of harm reduction in particular, because they're unlikely to ever say it's okay that people are using fentanyl within our walls. And so that's just like an example of why sometimes it's not really feasible to ask a correctional system to be a medical system, and that there's this inherent dual loyalty that's not really possible to bridge.
Thanks.
Yeah, I don't disagree. The ethical principles like non-malfeasance, which means do no harm, and beneficence and those sorts of things, often do run counter to what carceral facilities consider their business. And Laura's example is the most common one. I've worked with many facilities every facility I've worked at, you know, there's like one person who sells their Suboxone strip, and then it's like no Suboxone for anybody. You know, it's like that sort of law and order approach to issues. And, you know, it's not hard to understand where they're coming from, but the amount of harm that that policy then can cause is phenomenal. I remember we were working on this, these sorts of issues. There was just a paper in the New England Journal about Massachusetts jails and the outcomes of using buprenorphine treatment for opioid use disorder within the jails, and how that worked out in these facilities. And, you know, it was associated with pretty substantially reduced mortality, which we all expected, you know, when we were like, I remember being in conflict with a sheriff or two, like in the state house about this, you know, like this is like the nature of things. But if the medical side of the room is silent and the law and order side of the room is the only one talking, then, you know, you'll continue to get policies that are imbalanced and not fully considered.
And another way that med students can be super vocal in their own experience is to learn what the rules are about correctional officers and how they engage with patients in the hospitals themselves. And if you know, under the guidance of a supervisor, learning about that in ways that you can advocate for patients to protect their privacy and their experience in the hospital is another way that folks can really advocate as med students. Probably best under the supervision of a supervisor.
Bryan, any thoughts?
No, I agree with Matt and Laura, but I think they did a really good job of explaining the reasons why.
Absolutely. Just looking here to see. Yeah, I think we have another question. What policy changes are most urgently needed to ensure continuity of primary care for people before, during, and after incarceration?
Laura, that's you. Go for it.
I mean, so okay, so the most obvious or the most tangible answer right now is that there's an effort to expand Medicaid. Right now, the way Medicaid works is that no Medicaid funds can be spent for folks while they're incarcerated. There's a siloing of the healthcare systems, which causes a lot of problems for continuity of care for the individual patient. It also causes a lot of problems to silo the systems like that because it means that there's no way to hold correctional institutions accountable for their quality of healthcare. So for currently it's a state by state measure. Certainly would be possible at the federal level as well to allow for Medicaid funds to bridge that time, which again is something it has not happened here in Wisconsin. It has happened to a certain extent in Massachusetts, and so that's one thing. And then obviously this is super pie in the sky maybe, but certainly goes without saying that a single payer health care system, or a system at least where everyone has access to healthcare regardless of their income, is just crucial for health. It likely reduces recidivism and correctional involvement to begin with, and would eliminate a lot of these barriers to seeking care that we see after incarceration as well.
Super. Thank you so much. And any final comments from any of you? I just want to thank you so much. The end of the hour is upon us much faster than I thought it was going to be. I thank you, Laura, Matt, and Bryan, for sharing your time and shedding light on such an important part of medical care that we often don't think about and our students often don't learn about. You are all incredibly inspiring, and I love the message about how wonderful a field this is and how important and how necessary it is. So thanks again for your time and your willingness to share your knowledge and experience.
Thank you so much for having us.
Yeah, thank you for having me. Have a great day.
Thank you so much.
Thanks. Take care. Thanks everybody for coming.